Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Just recently, the Food and Drug Administration approved a supplemental new drug application for Xtandi, enzalutamide, for the treatment of patients with metastatic castrate-sensitive prostate cancer. It was about 30 years ago that we published an article in the New England Journal of Medicine about adding an anti-androgen to an LHRH agonist and improving outcome. Today, discussing this with us is a professor from Harvard, Chris Sweeney, who's a medical oncologist at Dana-Farber and a real leader in clinical research and care in men with prostate cancer. So, Chris, can you give us sort of an overview of this trial and what the implications are?
Thank you, David. It's a great honor to share the big picture of results from the study that we led called ENZAMET. It's a companion study to the ARCHES study that was used by the company for the label extension. And in both studies, hormonal therapy was the backbone with testosterone suppression, and the control arm had the agent that Professor Crawford was just talking about, bicalutamide, and the experimental arm had enzalutamide in place of that in the ENZAMET study. In the ARCHES study, it was just placebo. They didn't have bicalutamide. Because the ENZAMET study was started before the ARCHES study, the follow-up is longer. And what is very clear is that for all the patients who were enrolled, whether they had a low burden of cancer on their scans, whether they had a high burden with 4 or more bony metastases or liver metastases, or if they had a cancer that was de novo metastatic, namely cancer that was found for the first time on the scans when they were first diagnosed with prostate cancer, or relapsed later, we see a survival benefit in all versions of the cancer. Unlike chemotherapy, we tended to see the main benefit in those who had a high burden, more rapidly progressive disease. So this is an option for men with 4 pills a day added to the testosterone suppression. And it's also reasonable for men who aren't candidates for chemotherapy. So in 2019, 2020, when a patient presents with metastatic hormone-sensitive prostate cancer, and they're starting the testosterone suppression for the first time, the conversation is, are they fit for chemotherapy? What is the extent of their disease? And then you can work out what is the right treatment option. For some patients, it would be to get chemotherapy out of the way. For other patients, if they're fit for chemotherapy and have high burden, or go to the hormone treatment. If a patient has a low burden of cancer, starting the testosterone suppression and adding the enzalutamide would be also a very reasonable option. And I think preferable to starting chemotherapy where we don't see a clear signal of benefit.
All right. Well, thanks for sharing that with me and our audience, Chris. Yeah, we still see men that newly diagnosed metastatic disease that go on monotherapy with LHRH agonist or antagonist. Can you comment on that? How strongly you feel about should we add? You were the principal investigator on the CHARTED trial, which is the one that got docetaxel involved in early metastatic disease. So what are your thoughts about the monotherapy and where we should be going and what's the standards now?
I really think every man should be considered for adding something onto the testosterone suppression. And that's the default. Now that we have the options of abiraterone, docetaxel, apalutamide, enzalutamide, every man should be considered for one of those options based on whether they're fit for chemotherapy and the nature of their cancer. There are very rare examples or scenarios where you may not choose to do that because the patient isn't fit. So a very elderly man with a couple of bony metastases a few years after their radiation with congestive heart failure, some dementia, they could probably be managed with hormones alone. But that's the exception in 2020. We don't know how patients are going to respond to treatment until we start it. And I think the best way of increasing the chances that a patient will be alive at 3, 5, and 6 years longer is by going all in up front.
Very good. Your charted trial was one of the first trials that showed not just a couple month benefit, but way in excess of the year benefit. And I think we have to discuss that with patients. Listen, I want to thank you for sharing this late breaking news with us and the audience of Grand Rounds in Urology, and thanks for everything you've done to contribute to research in prostate cancer.
Just following from your lead, David Crawford.
Thank you.